Our brain is one of our most important organs. So imagine when a doctor tells you your brain has a cancerous tumor in it. The latest research here at the University of Kansas Cancer Center is helping those with brain cancer live longer while maintaining quality of life. Bench to Bedside starts now.
From the research bench to the patient's bedside, this is Bench to Bedside with your host, Vice Chancellor and Director of the University of Kansas Cancer Center, Dr. Roy Jensen.
Good morning. I'm Dr. Roy Jensen, Vice Chancellor and Director of the University of Kansas Cancer Center. Today on Bench to Bedside, about 89,000 people in the U.S. will receive a primary brain tumor diagnosis this year. And for those with cancerous brain tumors, life as they know it is changing, with most patients living up to 5 years after their diagnosis. Dr. Tolga Tuncer, who is a neuro-oncologist, and Dr. Wang and Dr. David Akhavan, who are both radiation oncologists, are today's guest. Good morning and welcome. There are lots of different types of brain tumors, and let's talk a little bit about that. Dr. Tuncer, which ones are the most dangerous?
Generally speaking, brain tumors are graded, not staged. This is an important concept. And generally speaking, most of the grade 3 and grade 4s will be aggressive brain tumors, and some of the grade 2s has an aggressive pattern of behaving. So they become challenging brain tumors.
Mm-hmm. So why are some brain tumors so hard to treat?
Yeah, that's an excellent question. There is surgically speaking, there are some tumors that are infiltrative in nature, despite our efforts of our excellent neurosurgeons and despite using multiple optical instruments. Still, we know that there is still some residual cells beyond the what seems as normal surgical margin. So that's one problem. The other problem is the drugs that we're using today are not crossing the famous blood-brain barrier that is called, which is has to be molecules that are neutrally charged, and they don't have a good penetration into the region of interest, which is the tumor. The blood-brain barriers are, we often hear this, they are leaky in some of the tumors, and some of the tumors, they have intact parts. So the medications are unreliably penetrating the tumor site. We have barriers also in clinical trial, which is one of the things that I give a lot of emphasis on. Nationally, we're at 11% or so in terms of clinical trial recruitment. There are some barriers to that, being location. Sometimes in one study they found if the travel time was less than an hour, you are fourfold more likely to be recruited in a clinical trial. Mm-hmm. So those are the main things, and there are some other challenges with the radiation, as my colleague Dr. Wang will probably delve into.
Mm-hmm. So who is at risk for getting brain cancer, and is it ever hereditary?
Yeah, generally speaking, if you bring all comers brain tumor-wise, 5 to 7% seems to be hereditary. There is a trial ongoing since 2004 looking into this, and then one of the interim reports was reported in 2017. Although a vast majority of the brain tumors does not seem to be hereditary, there's a couple of syndromes associated with that, like Turco syndrome or Gorlin syndrome or some other syndromes, but generally speaking, I would say 95% of the brain tumors are etiology-wise or origin-wise some form of ionizing radiation induced.
I see.
So, yeah.
So, what is the typical treatment for brain tumors?
Yeah, so this tumor was the first solid tumor that was described by the Cancer Genome Atlas, TCGA. It's impressive. I mean, this is the first tumor, and still, dial 14 years after, we still are struggling to find out a homogeneous nature of addressing things, because this is such a vastly different tumor, intra and inter tumor, meaning that within the tumor there's different parts of the tumor that is responsive to the same medication. Heterogeneous, in a heterogeneous disease like this, an algorithm such as removing as much as possibly, we call it a gross total resection of the tumor in its entirety if possible, and followed by radiation treatment with an oral by mouth chemotherapy, followed by more oral chemotherapy, is the basic algorithm. Of course, there's a lot of research going on from deviations of this, or to do something else, because in a disease that is so uniformly fatal and we're still lacking in understanding, the results are, as imaginable, very variable, in the sense of outcome is the prognosis of obviously differs so much that even in a grade 4 tumor like glioblastoma, the survival ranges from anywhere from 9 to almost 30 months, depending on the genetic composition of the tumor.
Dr. Akhavan, could you tell us about radiation therapy and exactly what that is, and how effective is it for glioblastoma and other brain tumors?
Thank you for having me, Dr. Jensen. Very happy to be here. So radiation therapy is a form of high energy X-rays, is the more common type. Other types of radiation therapy includes high energy particles such as proton therapy. It is a mainstay in standard of care for high-grade brain tumors as well as low-grade brain tumors. So it is effective as it is the standard of care. Often when surgeons can't completely remove the tumor, or if it's near a very sensitive structure, they can't be easily excised, we will use radiation therapy as a standalone treatment, in which case will be very effective, especially for things like brain metastases or meningiomas or low-grade tumors.
So metastatic brain cancer is caused by cancer cells spreading to the brain from a different part of the body. And Dr. Wang, I want to bring you in because that's one of your areas of expertise. Could you tell us a little bit about some of the radiation tools that can help with the treatment of brain metastases, or at least slow down the tumor growth, and just discuss, what is available in that situation?
Sure. The brain tumor, significant components of brain tumor are metastasis from other parts of the body. That is why systemic treatment like chemotherapy, other target therapy was not able to effectively control the brain metastasis. Currently, we still heavily depend on the local therapy such as surgery or radiation. Radiation is most components of treatment for brain metastasis. In KU Medical Center, we have all the available tools of radiation to treat brain metastasis. Typically for brain metastasis, if you have a small number of metastatic lesions, we commonly use radiosurgery, we call it SRS, to deliver high-dose pinpoint radiation to individual lesions. In this way, we can provide very high local control rate, but not really compromise patient quality of life in terms of the cognitive function. The other type of radiation treatment we call the whole brain. If the patient present diffuse numerous metastatic disease, we will try to treat the whole brain tissue to control existing tumor, but also prevent tumor recurrence. And the other unique treatment modality in KU is we have a treatment we call the gamma tel, which is we call the internal radiation. And this is a cesium radioactive material made as a tel, and after surgical resection, create a surgical cavity during the neurosurgeon procedures. We implant this cesium radioactive material inside of cavity, and this material will slowly release the radiation dose to the cavity to provide control of the tumor. And this is a unique treatment opportunity at KU. I think there are just few cancer centers in the nation have this kind of treatment modality. Currently, we are also have a randomized trial to evaluate this treatment, outcome. Randomized patient after surgery received the gamma-tel internal radiation versus external beam radiation SRS to the cavity.
I see. So, of those tools that you just described there, are any of those exclusive in this region to the KU Cancer Center?
I think a radiosurgery, we generally call external beam treatment, are available in most radiation oncology center, but gamma-tel may be one of institution in this region provide these services, but I think we're a major center and work with company. We're also working company to open additional trial for GBM, the high-grade gliomas too.
Mm-hmm. So Dr. Akhavan, it sounds like you've got quite a range of options available. How do you go about deciding which type of radiation therapy is appropriate for a specific brain tumor patient?
So it often starts at our neuro-oncology tumor board, where we have our multidisciplinary team of neurosurgeons, neuro-oncologists, as Dr. Tuncer, and our radiation oncology colleagues. And we look at the patient's age, the specific type of tumor it is and its location, whether we decide to do X-ray based radiation or proton radiation, or as Dr. Wang said, if it's a brain metastasis and it has a great resection cavity, then we'll consider gamma-tel clinical trial. So we have a lot of options at our disposal, and our multidisciplinary team comes together to decide what's the best option.
So something which I think this group of physicians is a great illustration of is the fact that for brain tumors, different types of doctors work together to create an overall treatment plan. And Dr. Wang, you lead our radiation oncology team for neuro-oncology. How do you develop these relationships and work together to identify what's the best treatment plan for each brain tumor patient?
And that is a great questions. I think for cancer treatment, it really is a truly teamwork. That's including all the field of the doctors, including neurosurgeon, medical oncology, radiation oncology, but also neuroradiology, pathology currently is very important too, because they provide more specific information to grading the brain tumors too. And because this is teamwork, and we are really working very closely with our surgical colleagues, medical oncology colleagues like Dr. Tuncer. We have a regular Monday morning tumor conference. We present most of cases of patients to make diagnosis and discussion treatment options, and we're working together corresponding to start treatment, like post-op treatment. If the patient needs a chemo radiation, then we'll see the patient, work with Dr. Tuncer, cooperate with his department to start concurrent chemo radiation.
Mm-hmm.
It's a truly teamwork. Without any of us, and we cannot do the better job for patient care.
It sounds like with all of these options, it's really important to carefully consider the approach that each patient is going to have. And I want to talk a little bit about why that makes it so important for brain tumor patients to get a second opinion for their cancer diagnosis. And one reason obviously is it may offer you peace of mind by kind of confirming the original diagnosis. And but Dr. Tuncer, how does a second opinion work for a brain tumor patient that presents to our facility?
At KU, we have all the right tools, right components to have a truly transdisciplinary collaboration, naming neuropathology, radiation oncologists, and medical oncologists, and of course the neurosurgery team. So one of the important things I always tell my patients is the when the clinical trial rate is so low, accrual-wise, nationwide, especially the second opinion is truly important when patients are looking for options, alternatives, or clinical trials, because looking at the NCCN, National Cancer Network guidelines, a regular oncologist can lay out generally a treatment algorithm. But when things become so different in terms of the patterns of recurrence, when there's a recurrent tumor, there's a difficult location, I think that's, or looking for a clinical trial, that's where the importance of a second opinion is. And I think we truly have all the right tools here at KU.
Mm-hmm. So if you're just joining us, we're here with Drs. Tolga Tuncer, Wang, and David Akhavan discussing the latest in brain cancer research and care. Remember to share this link with people you think might benefit from our discussion. Use the hashtag #BenchToBedside. So let's switch gears a little bit and talk about research, Dr. Tuncer. What is the difference between basic or so-called lab research and clinical research?
Yeah, basic research alludes to understanding the mechanisms of tumor formation in the molecular or immunological means, and it is done either called in vivo or in vitro, meaning in an organism or outside of a living organism. So before you go into clinical trials on patients, you need to get through this process. And then clinical trials refer to different phases of drug safety, then efficacy in a growing number of participants. We have 4 phases, generally speaking, starting from 30 to 100 patients in phase 1, looking at the safety of the proposed medication, to all the way to phase 4, which includes several thousand participants, looking at long-term effects of the approved drugs. So in between, there's all sorts of phase 2 and phase 3 trials.
Mm-hmm. So I want to go back to the laboratory-based research and talk about the fact that 5-year survival for people with glioblastoma is less than 7%, and obviously new treatment approaches are desperately needed. And one of those approaches is actually being led by our own Dr. Akhavan. Could you tell us a little bit about your glioblastoma work, Dr. Akhavan?
Blastoma research, it tries to design and harness the body's own immune cells, their T cells, to target the cancer cells and destroy them. T cells have the ability to target cancer cells if they're trained in the laboratory, very specifically with viruses to train them to target certain tumor antigens on the cancer cell surface. So we take blood. My laboratory takes blood from patients who are donating blood. We isolate their T cells and we find novel ways to train them in a dish to target the cancer cells. And then we model the patient by using a mouse, and we put the T cells back in the patient, in the mouse patient, if you will, who has a brain tumor, and evaluate ways in how the patient's T cells can eradicate the tumor. The ultimate goal is to take this T cell based therapy, also known as CAR T cell therapy, to clinical trials for the benefit of patients in the state of Kansas, to lead a potentially therapeutic and curative treatment.
So CAR T therapy obviously is one form of immunotherapy, but there are a number of others. And in fact, the immune checkpoint inhibitors have had a lot of success in a variety of solid tumors, in particular CAR T more so in the liquid tumors. What is their potential for use in glioblastoma, Dr. Tuncer, specifically the checkpoint inhibitors?
The success enjoyed with many hematological and solid tumors with immune approach has not been the case, unfortunately, partially due to a different biology of this brain tumor. I'm talking about primary brain tumors, where the tumor is relatively what we call cold, meaning that it's not it has an immunosuppressive environment. So that is one of the obstacles. The other one is the drug delivery. Couple of trials, unfortunately, with the immune checkpoint inhibitors have been negative. However, there is some design issues and there is some corollary molecule issues with these trials. So Dr. Akhavan's CAR T research, I think it's going to be one of the next things in the immune discovery of glioblastoma, which has a very, as I said, heterogeneous tumor, very immunosuppressive tumor. I think the future also will be a combination of using chemotherapy, immunotherapy, and then also electrical fields as well. In newer approach in the last 10 years or so, tumor treating fields, they call them.
Mm-hmm.
So,
okay. So Dr. Wang, given all the radiation approaches that we discussed earlier, I'm sure there's quite a bit of work going on trying to figure out the correct approach or the combination of approaches from radiation for these patients. And could you tell us a little bit about that in your research specifically?
Sure, yeah. In terms of the treatment for the brain metastasis, we still have a lot of challenge because when we treat individual lesions, there's a continual recurrence in the brain. And we do need some kind of a good systemic treatment to help to control recurrence in CNS, but also we're looking for different treatment modality of radiation whole brain combination with SRS to treat tumor efficiently, but also preserve patient cognitive function because, metastatic patient at this time can live in longer time. We want them living in the quality life. Mm-hmm. And additional treatment option for radiation is proton therapy, which is new for us, and we are very excited to have this treatment option. Proton therapy is mainly can protect more normal tissue to be readed and to protect more neurologic functions. Certainly, there's a lot of research component in proton therapy, like flash therapy, grid therapy, which have a significant therapeutic index to provide more enhanced radiation tumor control. And also other area is area we're working or we're very interested to see and the combination with immunotherapy, what is the synergistic treatment options, and because radiation has been proved can turn cold tumor cell to hot tumor cell to improve immunotherapy reactions too. This is the area we're working on that.
I see. So we're approaching the end of today's episode, and I have one more question for each of you, and I'll start with you, Dr. Wang. What are you most excited about in terms of the future for brain cancer treatment?
For radiation standpoint, like I just mentioned, we have this new proton facility. That's really create a lot of opportunity to serve patients in the region to provide the best care or best radiation treatment options. Like I said, this is a treatment that can really deliver high dose radiation with a decreased risk of damage to normal tissue. And other exciting area is teamwork and also the Akhavan's lab to looking for the immunotherapy options, CAR T cells and other checkpoint inhibitor, and hopefully we can identify some target area to improve treatment outcome.
Okay. Dr. Akhavan, same question for you.
Well, I hope to bridge the gap between laboratory-based research and clinical bedside-based therapeutics. My lab's ultimate goal is to design a therapeutic cure for patients with this devastating diagnosis, whether they're brain metastases or primary brain tumors. And my goal is to one day sit down with the patient in the clinic and say, we have options for you, don't worry, and this we're going to aim for a complete cure.
All right. Dr. Tuncer, how do you see the field of brain cancer research progressing over the next few years?
Yeah, despite being the first tumor that was decoded by TCGA, Unfortunately, we hadn't had much progress, so the next quantum leap will be an effort of multiple fronts. I think one of the things I see is going to be functional imaging, where we're going to be more accurately describe the tumors. It's going to be more AI, artificial intelligence, pattern recognition. So that's one thing. I think our radiation oncology has perfected since the time I was a resident versus now. There's a incredible precision accuracy. The problem is more defining the target. So that's where the imaging importance comes into play. Immunotherapy, working with CAR T or other types of immunotherapy, and understanding a better network between a synergistic effect of radiation and immunotherapy and other disciplines will be crucial. We got to increase the clinical trial accrual. We got to get off the barriers, loosen up the criteria a little bit for very strict inclusion criteria for clinical trials, and more awareness, of course, from the provider standpoint and the patient standpoint of availability of clinical trials. And I think it's going to be exponentially exciting the way I see, and there's going to be more need of neuro-oncology in the next few years.
All right. Well, I want to thank all of you, for being part of today's episode of Bench to Bedside. If you have questions or comments for today's guest, please leave them in the comments. To learn more about brain cancer, visit kucancercenter.org/brain cancer. That is it for today. Join us next week at 10 a.m. for Bench to Bedside. Thanks for watching. Subscribe to our Bench to Bedside podcast, now everywhere podcasts are available.